Observe the mechanical stress placed on the human shoulder joint during a heavy lift or a high-velocity rotation. Enveloping this joint is the deltoid and shoulder. Its primary functional classification is that of a chief abductor, providing the force needed to move the arm laterally away from the midline. Understanding how the deltoid generates this lifting capacity requires an analysis of its internal structural arrangement. The external contour of the shoulder is the product of three distinct muscle segments that do not function as a single unit. Medical texts define the deltoid through specific anatomical and mechanical properties. As noted under peculiarities, the muscle is divided into three distinct parts: anterior, middle, and posterior. It is also identified as a multipennate muscle, dictating internal fiber alignment. This architecture allows it to be the primary abductor from 15 to 90 degrees. To understand the origin of this lifting force, we must map the skeletal framework and the neurovascular supply that powers these fibers. The shoulder's lifting power is the result of its three-part multipennate design, which optimizes fiber density for these specific force factors. We begin with the foundational skeletal anatomy of the shoulder girdle. The deltoid utilizes a broad origin. The anterior section anchors along the anterior border and the upper surface of the lateral one-third of the clavicle. Moving laterally, the origin line follows the margin and upper surface of the acromion process. The posterior portion of the origin completes the curve along the lower lip of the crest of the scapular spine. From this sweeping U-shaped origin, the fibers converge as they move down the arm. All three segments converge at a single insertion point, the deltoid tuberosity, on the lateral shaft of the humerus. This wide to narrow scaffolding concentrates the mechanical tension of the shoulder girdle onto one focal point on the humerus. Overlaying the muscle fibers onto the skeletal frame reveals three distinct alignment patterns. Figure 6.2 illustrates peripheral and central fiber differences. Anterior fibers use a unipennate alignment, pulling in a single direction to drive flexion and medial rotation. Posterior fibers use identical alignment for extension and lateral rotation. However, middle fibers feature a complex multipennate architecture. In a multipennate arrangement, fibers attach diagonally to central tendons, like the barbs in a feather. This geometry increases the number of fibers packed into the same cross-sectional area. This increased fiber density provides a higher contractile force capability compared to parallel arrangements. This force is required to overcome gravity when lifting the weight of the arm through the arc of abduction. This multipennate architecture provides the mechanical torque required to power the arm's abduction past the initial 15-degree mark. Beneath the superficial muscle layer lies a set of critical anatomical structures. The shoulder joint itself is situated directly beneath the deep deltoid fascia. Also in close proximity are the subacromial bursa and the rotator cuff muscles, which sit immediately under the deltoid's mass. A key skeletal landmark here is the surgical neck of the humerus. The deep relations of the deltoid include the axillary nerve and the posterior circumflex humeral artery. These neurovascular structures wrap horizontally around the surgical neck of the bone. The deltoid acts as a physical shield for these structures, creating a protective vault for the vulnerable neurovascular network. The axillary nerve originates from the C5 and C6 nerve roots of the cervical spine. This vital pathway carries the electrical signal required to trigger the swift contraction of the deltoid muscle complex. The multipennate middle fibers are entirely dependent on this signal to generate lifting force. When the signal is uninterrupted, it results in the smooth abduction of the arm from 15 to 90 degrees. The lifting power of the shoulder is non-functional without the precise electrical delivery provided by the axillary nerve. While the multipennate fibers are biomechanically strong, their neurological supply is physically vulnerable. The axillary nerve is positioned directly against the hard bone of the surgical neck. This positioning makes the nerve susceptible to injury during trauma or a fracture of the humeral neck. Structural failure of the bone can compress or lacerate the axillary nerve as it is pinned against the surgical neck. The consequence of this injury is paralysis of the middle fibers, leaving the patient unable to abduct the arm past the 15-degree mark. Effective clinical analysis of the deltoid requires looking past the superficial contour to understand the skeletal and neurovascular dependencies that govern its movement.